clinical presentations. Then we moved on to talk about the clinical types of tetanus. We said basically we have generalized tetanus, local tetanus, neonatal tetanus, and cephalic tetanus. And we explain each of them, what is involved. Then I think did we start with the differential diagnosis? Oh, we didn't get there.
Please, we did not get there.
Okay, all right. So we'll start with the differential diagnosis. Basically, for tetanus, the diagnosis of tetanus is clinical. So we use the signs and symptoms. And these signs and symptoms like the rigidity, the dysphagia, all these will mimic a lot of conditions. So it's very important you are able to rule out tetanus from other conditions. So you could have strychnine poisoning. So one of the most common differential diagnosis you should always consider is strychnine poisoning. And basically, strychnine is usually found in rat poison. So rat poison, that's where you find strychnine. So for someone to take strychnine or rat poisoning, then one of the things you want to consider is, does the patient have any suicidal attempts? So you want to find out in the history, is there any history of suicidal attempts? Or the poisoning could be accidental. So it's not always intentional poison. You could also have accidental poison. Maybe you thought it was something edible and you took it. Meanwhile, it's poison. So it could be accidental. So all these you would have to consider. Then, if you really want to confirm whether what you are seeing is strychnine poisoning or tetanus, you can do blood or urine assay for strychnine. So you check the blood for the presence of strychnine, or you check the urine for the presence of strychnine. If you should see strychnine in there, then most likely the rigidity, the spasm would to rule out strychnine poison. The other differential diagnosis we also want to consider is patients with neuroleptic malignant syndrome. So NMS, neuroleptic malignant syndrome. And basically, this is one of the complications from use of certain drugs, usually the antipsychotics. So one of the complications of antipsychotics is neuroleptic malignant syndrome. And basically, this presents with symptoms that look like tetanus. Just that what can help you differentiate neuroleptic malignant syndrome from tetanus is that for this condition, there's usually hyperthermia. So when you check the temperature, temperatures are usually very high. You are getting temperatures of 38, 39, 40. Then you are thinking about neuroleptic malignant syndrome because this is characterized by fever. Then there's also altered mental state in neuroleptic malignant syndrome. And you also want to find out the history. Prior to these symptoms, did you take any drug that could have caused these symptoms? So if you look at the history and the patient might have taken any of these antipsychotics, then we are thinking more of neuroleptic malignant syndrome rather than tetanus. So these are some of the things that can help you differentiate, because the rigidity, the autonomic dysfunction, the spasms, you also see them in neuroleptic. But what helps you is the presence of fever in neuroleptic, which is usually absent in tetanus, and altered mental state in neuroleptic, which is also usually absent in tetanus. And if the patient has history of taking drugs that could have precipitated neuroleptic malignant syndrome, then you know very well that it's most likely neuroleptic malignant syndrome. All right. The next differential diagnosis I want us to talk about is stiff person syndrome. So we have a condition called stiff person's syndrome. So from the name, the patient would appear very stiff, and you may be thinking it's tetanus. So just like tetanus, the spasms that occur in stiff person syndrome are also worsened by certain stimuli like noise, light, touch. Remember during the clinical presentation, I mentioned that we isolate tetanus patient from the general ward to a side ward or a dark room, all because we don't want the spasms to be worsened by too much light, too much noise, and too much touch. The same thing also occurs in stiff person syndrome. The spasms that occur here are also worsened by light, noise, and touch. But what can help you differentiate from tetanus is that for stiff person syndrome, it's an autoimmune condition. So you can check for the presence of autoantibodies. So there are autoantibodies. Usually we call them glutamic acid decarboxylase antibodies. So anti-GAD. So anti-glutamic acid decarboxylase antibodies or anti-GAD antibodies. These antibodies, when they are present, you know very well that you are most likely dealing with stiff person syndrome. Aside that, there's also absence of trismus and facial spasms. So the typical lockjaw we see in tetanus is not seen in stiff person syndrome. That's that the patient will be stiff, but you wouldn't see lockjaw. Then facial spasms. So they'll have spasms all right, but they wouldn't have some on the face. Unlike tetanus, where you can have facial spasms that will manifest as the rhizus sardonicus. In stiff person syndrome, they do not have facial spasms, and there is also absence of trismus. Just that they may have other spasms that are worsened by light, noise, and touch. Then you could also check for presence of autoantibodies, which is the anti-GAD antibodies. If it's present, you know you are dealing with stiff person syndrome. Okay. The last differential diagnosis I want to talk about is drug-induced dystonia. So drug-induced dystonia. So basically, from the name, drug-induced, so it's caused by drugs, usually the antipsychotics as well. So dystonia, where you may have abnormal eye movement, abnormal head movement. You may also have spasms. So these spasms may mimic tetanus. So what will help you differentiate it from tetanus is for tetanus, what happens is there's spasms and rigidity. So the spasms are usually what we term clonic, and the rigidity is tonic. So there's a clonic phase and there's tonic contractions or rigidity. But when you look at drug-induced dystonia, all that happens is just clonic. So there's spasms, there's no rigidity. So you don't have rigidity, it's basically spasms. And you also have abnormal eye movement. So there's also abnormal eye movement in drug-induced dystonia. And these spasms that occur in drug-induced dystonia can be relieved by giving anticholinergics. So if you give anticholinergics like attain, benztropine, you can relieve these spasms that are occurring in drug-induced dystonia. Unlike tetanus, where the spasms do not respond to these anticholinergics. Drug-induced dystonia, you want to find out, is there any history of taking drugs that can cause dystonia? You also want to find out, is there any abnormal eye movement? Is there any spasms? And these spasms, is it just spasms throughout, or the spasms and rigidity? If the spasms throughout, abnormal eye movement, patient took a certain drug, then you are most likely dealing with drug-induced dystonia. And these spasms are also relieved by giving anticholinergics like attain and benztropine. Any questions? Are we okay?
Yes, please.
Okay. So let's talk about the diagnosis. So basically, all that I've been saying is the differential diagnosis. So the differential diagnosis is what you need to rule out before you can confirm that this is tetanus. So for the diagnosis of tetanus, I've already told you it's clinical. When we say clinical diagnosis, basically we are looking at history and also clinically examining the patient for the possible signs and symptoms you expect to see. So for tetanus, we've gone through the signs and symptoms. We expect that before you say the patient has tetanus, you want to know whether there's an antecedent injury. Was there an injury before these symptoms started? You want to find out, did you step on something? Did you get a cut? Like you want to find out how this exposure happened. Once you've established there's an antecedent injury, you want to find out the symptoms. Do you have lockjaw? Do you have any facial spasms, rigidity, the opisthetonus, rhizus sardonicus, dysphagia, and all that, autonomic instability? So these are the signs and symptoms you want to find out. Once you have these established, and you look at the differential diagnosis, you've ruled out all the possible differential diagnoses. You know very well that none better explains the symptoms of the patient other than tetanus. Then we can say your diagnosis has been confirmed. So you don't need any laboratory test to confirm tetanus because the organism is very difficult to grow. You can't go and do cultures. Then the tetanus specimen, trying to test for presence of tetanus specimen, the laboratories do not have the facilities to run such lab. So basically, we use the history and the signs and symptoms. But one thing you could also do at the bedside is what we call the spatula test. So the spatula test is one bedside examination you can do. And for this test, basically all that you need to get is a spatula. So for a normal patient, for a normal person, let's say when you are brushing your teeth early in the morning and you attempt to brush your tongue, you try to go very deep down your throat. You realize that you gag. You have a gag reflex that helps you to gag it as if you want to vomit because it's going deeper. But for someone with tetanus, they tend to lose a little of their gag reflex. And because of the spasms of the masseter muscles, if you try to push down a spatula down their throat, instead of gagging it out, they rather clench their teeth on it. So they clench their teeth on the spatula firmly. So it's difficult removing the spatula from their mouth. But for a normal patient, when you push down the spatula down their throat, they rather gag it out. So that's a bedside examination you can do to see whether the patient has tetanus. So for the spatula test, once the patient clenches their teeth on the spatula and do not allow you to pull it out easily, then that's a positive test for tetanus or a positive spatula test for tetanus. So that's another way of diagnosing. So it's not done in isolation, but based on the signs and symptoms, the history, and the spatula test, you can diagnose tetanus. Then you also rule out the possible differential diagnosis. Any questions? Okay, so let's move to the management. So for the management, we are looking at certain treatment goals. So at the end of the management, we want to achieve certain things. So one of them is we want to relieve the signs and symptoms, usually the spasms. So we want to relieve the spasms or control the spasms. So that's one of the treatment goals you want to achieve. You also want to neutralize any unbound toxins. You want to neutralize unbound toxins. So the tetanus spasmin we are talking about, when it's bound to the nerve. Yeah, so I was talking about the tetanus spasmin. So for the tetanus spasmin, when it's bound to the nerves, we call it the bound toxin. The one that is not bound to the nerves are the unbound toxins. So what you can do is you can neutralize the unbound toxins. So that can be done in tetanus. Then you also want
Hello. Hello, Dr. Ishak. Please, we can't hear you.
hello, can you hear me now?
Yes, please.
Okay, all right. So I was talking about neutralizing unbound toxins. So that's one of the treatment goals. Then you also want to eradicate the causative organism. So you know tetanus is caused by an infectious pathogen. So you also want to eradicate the causative organism. Then you also want to prevent complications, and you also want to actively vaccinate the patient. So usually most of the patients that will come with tetanus and all that, they are usually unvaccinated because if you are vaccinated, you will be protected. So it's an opportunity. Once they come, you also want to take that opportunity to vaccinate them, protect them from further exposures. So that's the treatment goal. But if you forget any of these things, as usual, for treatment goals, you want to what? Relieve the signs and symptoms. You want to prevent complications. You want to reduce morbidity and what? Mortality. And you want to what? Improve the patient's quality of life. These are usually four constant treatment goals that you shouldn't always forget. But the specific ones, tetanus is you want to relieve the spasms, eradicate the positive organism, neutralize the unbound toxin, um, and also immunize the patient. So you try to go through how you'll be able to achieve these treatment goals. So the first one we talk about is how to control the spasms. If you remember from the pathogenesis, I told you that the tetanus spasmin inhibits the release of inhibitory neurotransmitters, GABA and glycine. So once these are not released, what is going to happen is the excitatory arm takes over, causing these hyper excitability, the spasms, the rigidity, and all that. So we want to control these spasms. And how do we control these spasms? What drugs do we give? Anyone?
Hello, Doc.
Yeah.
Yeah, I think you can give aclofen.
Yeah. So you can give something to relax the muscles, baclofen. So baclofen can be given. That the recommended route is usually the intrathecal, so into the spine, intrathecal. So you have to get the injection into the spine. Yes, the baclofen injection is not readily available. So when we are giving baclofen, we tend to use the oral, but the recommended from the guidelines is the intrathecal baclofen. Aside that, what again can be used to control the spasm?
Yeah, we can do
You can do what?
Davulam.
Yeah.
We can also do lorazepam.
Okay. So GABA is not released. So we need something that will mimic
Oh,
the effect
Dr.
of
Ika.
GABA. So we want to give benzodiazepines or barbiturates. Benzodiazepines and barbiturates
Sir,
are
please, we're not hearing you at some
GABA
point.
modulators. So they act like GABA.
Sir,
Basically, the difference in their mechanism is
Hello,
hello,
Dr. Ishak.
hello.
Hello, Dr. Ishak. Please, we could not hear you.
Okay,
Could you
can
kindly
you hear
start?
me?
Yes, we can hear you now. Hello. Hello.
Hello, can you hear me?
Please, we can hear you now.
Yeah. So I was talking about the use of benzodiazepines and barbiturates. Hello, can you hear me?
Please, we can hear you.
Hello. So I was talking about the use of benzodiazepines and barbiturates and an allosteric site on the GABA-mediated chloride channels. So ideally, GABA is what is supposed to bind to the pins that will bind to an allosteric site on the GABA-mediated chloride channels. Once they bind to these GABA-mediated chloride channels, they cause the opening of these GABA-mediated chloride channels. And you have influx of chloride ions into the
sir,
channel.
please, we lost you at some point.
Hello.
You
So all that I've been saying, you didn't hear.
just a bit, but at some point you went off again.
Talking about the GABA, how the benzodiazepines act. So basically, they bind to GABA-mediated chloride channels. And what they are supposed to do is they will cause the opening of these GABA-mediated chloride channels. And once the channel is open, it allows for influx of chloride ions into the cell. And this is supposed to provide inhibitory effect. And it's supposed to be done by GABA. But this time around, GABA is not being released. So we are giving benzodiazepine that acts as a GABA modulator. So it binds to an allosteric site on these GABA-mediated chloride channels to cause the influx of chloride ions. So that helps with the inhibitory effect. It's the same mechanism for barbiturates, just that the difference in the mechanism is that for benzodiazepines, they increase the frequency of opening of these GABA-mediated chloride channels. So for example, if these channels are supposed to open 5 times in 1 minute, once you give benzodiazepines, they'll open like 10 times in a minute. So the frequency of opening has been increased. Whilst the barbiturates, they increase the duration of opening of the GABA-mediated chloride channels. So if ideally the channel is supposed to be open for 10 seconds, when you give barbiturates, it will prolong the opening to about 20 seconds. So the duration of opening of GABA-mediated chloride channels has been increased. So that's the difference in the mechanism. But basically, they are all doing the same thing. So once you have chloride channels being influxed, you have inhibitory effect, and that relieves the spasms we see in tetanus. So that's how you manage the spasms. So usually we don't do them in isolation. We try to alternate. So maybe you can do phenobarb, 100 to 200 milligram TDS. Then diazepam, maybe 20 milligram TDS. Then you alternate them. So maybe every 8 hours or every 4 hours. So you give your phenobarb, the next 4 hours, you give your diazepam, the next 4 hours, phenobarb, the next 4 hours, diazepam. So that's how we alternate these drugs. Is it clear?
Sir, please
Are you okay?
can you repeat the drugs part.
Sir, please, I have a question.
Okay.
And please, my question is, why
Okay, go
are
ahead.
they alternated? Why don't you give just one drug, but then you alternate them?
So the issue about tetanus is these spasms are difficult to control. So you give just diazepam, you would have to give a lot of doses of diazepam to control the spasms. So there's been instances where you can do diazepam up to 600 milligram a day for just the spasms. The spasms are very difficult to control. So you try to give other agents, because if you are giving diazepam 600 a day, you know the side effects, respiratory depression, and the fact that diazepam, the vehicle contains propylene glycol. If you are doing up to 600 milligrams, the risk of lactic acidosis is high. So all these are considered. So for phenobarb too, if you are doing phenobarb alone, you know the risk of respiratory depression. Already, the tetanus itself can cause respiratory depression. If the spasms gets to the diaphragmatic muscles, they can cause that. So giving high doses of just one agent, risk of respiratory depression is high.
Okay, thank you.
Mind you, most of these sedatives cause respiratory depression. So we try to alternate, do low doses and try to alternate them rather than just doing high or just one of them. Any other question? Okay,
Hello, sir.
let's talk about the next treatment goal. So, okay,
Sir,
go
please, can you
ahead.
take the process again for phenobarb and diazepam?
So the doses I gave are not fixed doses. So I just gave a dose to illustrate the how you do the alternation. So the doses can be higher based on the signs and symptoms. But I usually start 10 to 20 milligram of diazepam every 6 to 8 hours. Then phenobarb 100 to 200 every 6 to 8 hours. You could even add chlorpromazine. So chlorpromazine also around 50 to 100 milligram every 6 to 8 hours. All these are not fixed. So you'd have to look at your patient and titrate based on the condition. Any other questions?
Sir, please, I want some clarification. I'm a bit confused. Um, with the drugs parts, you spoke about doing the changes after 4 hours, but now you're talking about doing each of them between 6 to 8 hours. So, can you please clarify between like the duration and also the changeover? I don't really get it.
So we are talking about alternating. So alternating can be done based on how the therapy is. So I said if you are doing, say, phenobarb, 100 milligram TDS, diazepam, 20 milligram TDS. TDS means every 8 hours, but you don't wait for 8 hours. So if I give diazepam now, you don't wait till the next 8 hours to give another dose of just the diazepam. So before the 8 hours reach, in between there, you have another 4 hours, 4 hours. So from the first dose, the next 4 hours, you can give your phenobarb. You get it? And the next 4 hours, which is 8 hours, will be the TDS for the diazepam. So assuming it's 08, 08 and 16 for the diazepam, which is 8 hours in between. So the phenobarb will come in around the next 4 hours from the first dose of the diazepam. Then the next 4 hours from the 8th hour. So that would be 12 hours. And the next 4 hours from the 16th hour. So essentially, you've done TDS for chlorpromazine and phenobarb. You've also done TDS for diazepam, but you've alternated them. You didn't just give one and wait for the one to finish before you give the other. I don't know if you get it.
Yes, sir, I do. Thank you.
Okay. Any other questions?
So please, about the chlorpromazine
Yeah.
that you mentioned, will it be more for the sedation?
Is there only be more for
Sedation, because I'm trying to relate its activity with the.
you can hear?
I'm asking about the chlorpromazine you mentioned. How would it affect or how would it minimize the spasms?
So chlorpromazine has muscle relaxing effect. So we are looking at giving something that will relax the muscles. The patient has spasms. So we are giving baclofen, we are giving phenobarb, we are giving diazepam, we are giving chlorpromazine. All these have muscle relaxing properties. So that's why we are giving them.
Okay.
All right. Let's move on to talk about how you eradicate the organism. So we said the organism is an anaerobic organism. And basically, we need something that has a very good anaerobic coverage. And looking at the various antibiotics, you would definitely want to use something that has a very potent anaerobic coverage like metronidazole. So that's the preferred first line agent that are used for tetanus. Metronidazole.
Hello, Dr. Ishak.
And
Could you
usually
kindly repeat
before
that?
metronidazole, can you hear me?
Yes, please.
So I was talking about eradicating the organism. The organism is an obligate anaerobe. So we want something that has very good anaerobic coverage. So that is why we are using metronidazole as the preferred first line because of the good anaerobic coverage. Before metronidazole, what was the first line was benzapenicillin, which is also known as penicillin G. But the issue with benzapenicillin is able to mimic the effect of tetanus spasmin. And this mimicry is done by the inhibition of GABA. So benzapenicillin or penicillin G is able to inhibit the release of GABA. Once you inhibit the release of GABA, you are acting like tetanus spasmin. So they did a study and they realized that patients who were put on benzapenicillin required more doses of benzodiazepines to relieve the spasms because the benzapenicillin they were giving was acting just like tetanus spasmin. So it was causing the spasms to worsen and they needed more doses of benzodiazepines to control the spasms. Unlike the other group of patients who were randomized to receive metronidazole, they required lesser doses of benzodiazepines. So because of that, now the preferred is metronidazole. But you could also do benzapenicillin. It can also be used. Other alternatives are clindamycin. We said the organism is anaerobic. So we need something that has very good anaerobic coverage. So clindamycin can also be used. Then because it's also gram-positive, more gram-positive, benzapenicillin, erythromycin, vancomycin, all these are alternatives. But whenever you want to use an antibiotic, the preferred first line is metronidazole. Are you okay?
Yes, please.
Okay. So for metronidazole, usual dose we do is we do the IV metronidazole 500 milligram TDS or QID for 7 to 10 days. Usually the QID is preferred. So IV metronidazole 500 milligram QID for 7 to 10 days. So that's the dose we do for metronidazole. Okay. Let's move on to talk about how to neutralize the toxins. We said for tetanus spasmin, the toxin can bind to the nerves and the ones that are not bound to the nerves. For the ones that are bound, you can't do anything about them. They'll forever remain bound. So that's the issue. So unless the body is able to regrow new nerves, these ones would forever remain bound. But what we can do is we can neutralize the unbound ones, the ones that are yet to bind to these nerves. You can give something to neutralize them. So usually we give what we call tetanus immunoglobulin. So tetanus immunoglobulin. And for tetanus immunoglobulin, we have two main types. We have one from humans and we have one from horses. So the ones that are obtained from humans is termed the human tetanus immunoglobulin. And the one that is obtained from horses is termed equine. So equine. An example of this equine immunoglobulin is the ATS we know. So the ATS we see is from horses. So it's equine. And ATS stands for anti-tetanus serum. So anti-tetanus serum. And that is obtained from horses. And we also have human tetanus immunoglobulin from humans. So basically, these are already formed antibodies. So these are already formed antibodies you are getting from either horses or humans. So when we inject you with these already formed antibodies, what we are trying to do is passive immunization. We introducing already formed antibodies into your system to neutralize the unbound toxin. This is a passive immunization. We are not activating your immune system to produce antibodies, but rather we are giving you already formed antibodies from either horses or humans to neutralize the unbound toxins. And this usually for the human tetanus immunoglobulin, that's the preferred one because it's from humans, the risk of allergic reaction is low compared to the one you obtain from horses. So that's preferred. Just that the human tetanus immunoglobulin is more expensive and it's not readily available compared to the ATS in our setting. But when you go to the developed countries, they tend to have the human tetanus immunoglobulin more. So when you check your BNF, your Medscape, your other references, you realize that you only see human tetanus immunoglobulin. You wouldn't see ATS there because now what they use there is human. They don't use ATS. But in our setting, we tend to use ATS, especially the patient can't afford the human tetanus. All right. So for the dose we give, the dose for human tetanus immunoglobulin is 3,000 to 6,000 units start. So you give 3,000 units to 6,000 units start. So that's the dose range for human tetanus immunoglobulin. Just that now recent guidelines, the CDC recommendation 2020 is now saying that when you give 500 units start is enough to neutralize the unbound toxins. So the dose range is 3,000 to 6,000. But if you give 500 units start, you are still correct because recent guidelines is saying 500 units start is enough to neutralize. So that can also be done. If you are to use the ATS, I told you the reference materials do not have ATS. So the dosing is based on the product literature. So when you look at the product literature for ATS, they talk about giving 50,000 units on the
Hello, Dr. Ishak. Please, your line is breaking.
one and day two. Then 10,000 units on day 3, day 5, and day 8.
Ishak,
Hello, can you hear me?
Please, your line was breaking. Could you kindly start again?
Can you hear me?
Yes, please.
So I said we give ATS 50,000 units on day 1 and day 2, then 10,000 units on day 3, day 5, and day 8. So that's the dosing for ATS, 50,000 units day 1, day 2, then 10,000 units day 3, day 5, and day 8. And this is giving us IM. So you do IM usually at the deltoid muscle, that's around the shoulder or around the thigh. So anterolateral part of the thigh, usually in children. You want to avoid the gluteal, the buttocks, because of the risk of sciatic nerve injury. So most of the time, IM deltoid for adults, then anterolateral part of the thigh, usually for kids. Any questions? Okay, let's talk about how we can actively immunize the patients. So once they come, so you want to know whether the patient has previously been immunized or not. So at the hospital, you realize that some will receive ATS and TT, some will receive just TT. I didn't talk about TT. TT is basically tetanus toxoid. And TT is tetanus plasmin that has been inactivated by formaldehyde. So it's basically the tetanus plasmin that has been inactivated by formaldehyde. So that's TT. And when we give you TT, the purpose is we want to actively immunize you. So it's an inactivated vaccine. Once you are injected with this inactivated vaccine, it primes the immune system to produce antibodies. So you produce antibodies against the inactivated vaccine. And that is what we call active immunization. And we said ATS is for passive immunization. Some patients will receive ATS, some will receive TT, some will receive both. So that's what we want to know. Which people receive what?
Hello.
So before you give any tetanus injection,
Hello.
you want to find out, one, the immunization history of the patient. And the second thing you want to find out is the type of wound, whether it's a clean wound or a tetanus prone wound.
Hello, Dr. Ishak. Could you kindly
Hello, can you
talk
hear me?
about, yes, please. Could you kindly come again with the fact that it's an
Hello, can
inactivated
you hear me?
vaccine? Yes, please. Could you kindly start from the point where you spoke about it being an inactivated vaccine?
So I said TT is basically an inactivated vaccine. You inactivate it with formaldehyde, and the purpose is you want to give this inactivated vaccine to prime the immune system to produce antibodies. So that is active immunization. You want to actively immunize the patient. And I said some patients will receive just ATS, some TT, some both. So we want to understand which people receive which of the vaccines. So before you give any tetanus injection, you want to find out two things: the immunization history of the patient, and you also want to find out the type of wound, whether it's a clean wound or a tetanus prone wound. These are the two questions you want to find out. So that's what we want to discuss. So the first thing we'll talk about is patient who has never been immunized. So no immunization history. At times, when the patient comes, it's very difficult to tell whether this patient has been immunized or not. We ask them, they seem not to have any knowledge about whether they've been immunized or not. Such patients, you consider them as unknown immunization history or no immunization history. So whether they know or whether they don't know or they've never received, you clump them together as no immunization. So for such patients, we want to consider, is the wound a clean wound or a tetanus prone wound? So you should understand what a tetanus prone wound is and what a clean wound is. So when we say a wound is tetanus prone, basically we are looking at any wound that is contaminated with soil, feces, saliva, or any foreign material. So that is why when you step on a nail, you want to go for tetanus injection, because you are dealing with a wound that might have been contaminated with soil. Or if you get a bite from an animal, you want to go for tetanus because that wound may have been contaminated with saliva. Then any wound contaminated with feces is also tetanus prone, because we said the organisms live in the gut of animals. So feces is tetanus prone. Then any wound that's contaminated with foreign material like the nail or any sharp object. All right. The other thing about tetanus prone wound is if you have compound fractures or open fractures. So those are surgery. You know that types of fractures, we have closed fractures and we have open fractures. So if your arm is broken, but you don't see any break in skin, you don't have the bone piercing through the skin, there's no wound there, that's a closed fracture. But if you get a fracture and you can see the tissues are broken, you can see um, a bone hanging out and all that, that's an open fracture or compound fracture. So that's the other name for compound fracture, open fractures. So if you have such fractures, that's also tetanus prone. You have to get tetanus injection. Then if you have burns wound lasting for more than 6 hours without skin graft, so if you should get burns, you are supposed to get skin graft, especially the extensive burns. They should do skin grafting. So if you should go beyond 6 hours without skin graft, it's also a tetanus prone. So that one requires tetanus injection. Then if you have maybe puncture wounds, so deep penetrating wounds, like someone stabbing you with a knife, you stepping on a nail, gunshot, all these are puncture wounds. They go deep into the tissues, and that creates that anaerobic environment for the organism to thrive. So these are also considered tetanus prone. So if the wound is neither of all the things I've said, then we are looking at a clean wound. So maybe you are cutting onions in the kitchen and the knife you are using cuts you on your finger. That's not tetanus prone. A lot of us have had cuts and we never developed tetanus because these wounds are not tetanus prone. But the moment that wound is contaminated with soil, feces, saliva, or foreign material, or you have a compound or open fracture, you have Ben's wound lasting for more than 6 hours without skin graft, or you have puncture, like stepping on a nail, gunshot, someone stabbing you with a knife and all that. These are puncture or deep penetrating wounds. So all these are tetanus prone wounds. All right, so that's how you are able to tell whether this wound is tetanus prone or is a clean wound. So I was talking about which people will receive ATS, which people will receive TT. So if the patient comes and they do not have any immunization history and they are presenting with a clean wound, for clean wound, there's no need giving ATS because we give ATS to neutralize the tetanus specimen. So if the wound is clean, it's assumed that you don't have any tetanus specimen in there for you to neutralize. So for a clean wound, if the patient comes and they've never been vaccinated before and they present with a clean wound, you do not give ATS. You only give TT because the patient doesn't have any immunization. So you only give TT. But if this same patient presents with a tetanus prone wound, for tetanus prone wound, because it's tetanus prone, we need to give ATS to neutralize any unbound toxins. So we give ATS to neutralize unbound toxins. Then we need to give TT because the person hasn't been immunized. So that's the difference. Clean wound, we only give TT, no ATS. But tetanus prone wound, you give both ATS and TT. Are we clear on that?
Yes, please.
Okay. The next one is if this patient if you have another patient presenting with so they present with either tetanus prone wound or clean wound, and they tell you, oh, they've received tetanus injection before, but they don't remember the number of doses, or they've received, ideally, you're supposed to receive 3 doses. So 3 doses make up the primary immunization. You say your immunization is complete when you receive 3 doses. So when you receive one now, 1 month after you receive the other one, then 6 months after you receive the other one. So that forms primary immunization. So that's complete vaccination. So if the patient tells you, oh, they've received 1 or they've received 2, that means it's incomplete vaccination. So someone with incomplete vaccination who presents with a clean wound, because the wound is clean, you don't need any ATS to neutralize. All that you need is TT because the patient doesn't have a complete immunization. So you need to give TT to help complete the immunization. But because the wound is clean, there's no need for ATS. If this same patient, incomplete vaccination, presents with a tetanus prone wound, because the wound is tetanus prone, you have to give ATS to neutralize the unbound toxin. And you also need to give TT to also actively immunize the patient. So you give both ATS and TT for tetanus prone. You only give ATS, you only give TT for clean wound. So this is a patient with incomplete immunization. They received either 1 or 2 of the vaccination. That's incomplete. The next one is for someone presenting with complete immunization, meaning that they've received 3 doses. So complete immunization, they've received 3 doses. So if this patient presents with a tetanus prone wound, Because the wound is tetanus prone, you have to give ATS to neutralize the unbound toxin. So that one is established. But do you give TT? For TT, you only give if the last dose of the patient vaccination is more than 5 years. So someone who has received a complete immunization, 0, 1 month, 6 months, if the last dose is more than 5 years, ideally, they are supposed to give booster doses every 10 years. After the primary immunization, the 3 doses, you are supposed to give booster doses every 10 years. So if you look at the last dose of your primary immunization, it's more than 5 years, then the patient has to receive TT in addition to the ATS for tetanus prone. But if it's less than 5 years, you don't need to give TT. You only give ATS and you wait till the next time the patient is supposed to receive the booster. Then you give your TT. If this complete immunization patient should present with a clean wound, I told you don't need ATS. So no ATS. But you give TT if the last dose of the patient immunization is also more than 5 years. But if it's less than 5 years, you don't give. All that you need to do is you wash the wound with soap and water. So that's the recommendation for complete immunization. And the last one is someone with full immunization or someone who is fully immunized. So when we say someone is fully immunized, we mean the patient has received 5 doses of TT. So that means they received the 0, the 1 month, 6 months. That forms the primary, which is complete. After that, they are supposed to receive booster doses every 10 years. So they've received 2 booster doses in addition to the 3 primary immunization. So that means they've received 5 doses. Such patients are said to be fully immunized. If the patient who is fully immunized presents with tetanus prone wound, because the wound is tetanus prone, you would have to give ATS. We give ATS to neutralize. But for the TT, you don't give TT because the patient is fully immunized. The only time you give TT again is if the last dose of the patient TT is more than 10 years. So for fully immunized patients presenting with tetanus prone wound, if the last dose of the TT is more than 10 years, then you give TT in addition to the ATS. But if it's less than 10 years, there's no need giving TT. You only give the ATS. So that's for tetanus prone wound. If it's a clean wound, you don't need any ATS. And you also don't need TT because the patient is fully immunized. Unless the last dose of the full immunization is more than 10 years, then you may want to give TT. Other than that, fully immunized, clean wound, no ATS, no TT. Are we okay?
So please, I thought you said 5 years.
5 years is for complete immunization. Fully immunized is 10 years. Any questions? Is it clear? Okay. So the last thing I'll talk about before we end this how to manage the autonomic instability. So for the autonomic instability, basically what happens is the tetanus specimen is able to inhibit the release of catecholamines from the adrenal gland. So the adrenal gland is supposed to release catecholamines like noradrenaline, dopamine, adrenaline. These are catecholamines. So tetanus specimen is able to inhibit the release of these catecholamines. So realize that in terms of sympathetic and parasympathetic, there will be imbalance. Autonomic basically means sympathetic and parasympathetic. So you have periods where the patient is sweating. You have periods where the patient is having hypertension. Other periods too, there may be hypotension, tachycardia, bradycardia. So we need certain agents that can help regulate the autonomic instability. And the preferred agent we use is max sulfate. So magnesium sulfate is what is used in controlling the autonomic instability. And basically it's able to inhibit um, neurotransmission. So it's able to stabilize the release of catecholamines and also inhibit neurotransmission. So that's how it's able to help control the autonomic instability. Other agents have also been tried. Morphine has also been used. Um, Beta blockers, especially labetalol, esmolol, these have been used. Propranolol was used, but there was increased mortality with propranolol. So propranolol is no more recommended. If you want to use a beta blocker, labetalol or esmolol, these are the preferred ones. But essentially, in terms of autonomic instability, the preferred agent is max sulfate. Other alternatives are the morphine and the beta blockers, but the preferred is max sulfate. Any questions?
Please, can you go over the MOA for max sulfate?
Can I go over it?
The MOA from the mode of action for max sulfate. I didn't get that part. Oh.
Yeah, so I said it's able to regulate the release of catecholamines from the adrenal gland and is also able to inhibit neurotransmission. So that's how it's able to regulate the autonomic instability. Any other questions? All right, so if there's no other questions, we'll end the discussion here. Hopefully, the next time we meet, we'll talk about rabies. So we are talking about vaccine preventable disease. So we've talked about tetanus. The next one is rabies. So kindly read on rabies. The next time we meet, we'll solve some questions on tetanus. Then we start with discussions on rabies. If there's no other questions, have a good evening.
Thank you, Dr. Ishak. Good night, everyone.